Honor and pleasure for me to be with you in this important meeting, and thank you for your invitation. And I am going to speak about the topic challenges in initiation or intensification of injectable therapy. What about issues in the management of injectable therapy? Delays in initiation and intensification of insulin therapy, treatments option for patients controlled on basal insulin, how to intensify basal insulin therapy with GLP-1 receptor agonist, barriers in the initiation of injectable therapy, why does intensification of insulin therapy not happen in patients with type 2 diabetes, what option for type 2 patient and controlled on basal insulin therapy. About this case scenario, 64-year-old woman with type 2 diabetes for 7 years. We see that she's obese. She has not good HbA1c. Her lipidic parameters are not bad because she received treatment. And her renal function is limited. She was on lifestyle management, metformin and vildagliptin and glimepiride. She received treatment for hypertension and statin for her dyslipidemia. This patient has hypertension, dyslipidemia, obesity. 1 year ago, she had 7.2 on HbA1c. Now her HbA1c is not good. It's important to discuss with this patient the initiation of basal insulin therapy or GLP-1 receptor agonist or both of them. We know that type 2 diabetes is a chronic condition with progressive loss of beta cell function. We know that improving glycemic control reduces the risk of long-term complication, and every 1 point drop in HbA1c can reduce long-term diabetes complication. All the type of insulin offers maximum of HbA1c reductions. And what about insulin therapy? We have some advantages. Oldest of the currently available anti-glycemic therapy, most effective in improving glycemic and achieving therapeutic goal, beneficial effects of triglyceride and HDL. But we have some disadvantages, weight gain and risk of hypoglycemia. We know that early insulin treatment prolongs beta cell function and glycemic control better than other treatment and particularly oral agent. What about the rationale of starting with basal insulin? Predominant fasting hyperglycemia, simple titration, effective, safe, lower risk of hypoglycemia, and less weight gain, and anytime injection. To have a strategy for the treatment of insulin, we start with basal insulin plus oral agent. We can use premix and without oral agent, and we can use prandial insulin. And when we want to intensify regimens, we go to basal plus therapy, premix in 2 days or 3 times a day, and basal bolus therapy. It's important to say that up titrating basal insulin may not achieve HbA1c and target and may increase risk of hypoglycemia. And in patient adherence with medication for type 2 is not optimal, but with sulfonylurea, with thiazolidinedione, with DDPP4 inhibitor, or with basal insulin. And as recommended by other AASD, if we want to introduce insulin, particularly when injectable therapy needed to reduce HbA1c, we consider GLP-1 most prior to insulin. And if above HbA1c, we add insulin basal. We can use the insulin basal if a GLP-1 is not appropriate. And after, with adult basal insulin, we can use analog or bedtime NPH. If above HbA1c, despite the adequately titrated basal analog or bedtime NPH, we go to intensify about add prandial insulin, or in bedtime NPH, consider twice daily or three times a day. And if above HbA1c is not good, we intensify stepwise additional injection of prandial insulin and consider twice daily insulin and using consider self-mixed or split insulin regimens with titration. What about now GLP-1 receptor agonists benefits? Low risk of hypoglycemia, increase insulin secretion in glucose-dependent way, improvements in cardiovascular markers, blood pressure, triglyceride, low-density lipoprotein, cholesterol, use as an alternative to metformin or add-on, promotes weight loss. We know that benefits of GLP-1 in patients with type 2 are cardiovascular safety, particularly with liraglutide and with semaglutide and primary endpoint. We know that SGLT2 inhibitors can be used to protect patients with high risk cardiovascular and to reduce the risk of cardiovascular events. Fewer type 2 diabetes patients had a target when titrated insulin injectable. In the Panorama study, we see that only 36.1% are on the target. Why does intensification of insulin therapy not happen in many patients with type 2 diabetes mellitus? Because clinical inertia, and clinical is not only from physician barriers, it's also for patient barriers. And second point is because progressive nature of disease, of diabetes. And when we want to intensify a treatment for type 2 diabetes and controlled on basal insulin, we add oral agent or add short-acting insulin at mealtime, or to switch to premixed insulin, or to novel insulin combination, or use basal insulin GLP-1 receptor agonist combination. Insulin degludec fixed ratio combination versus basal bolus, proportion of patients achieving HbA1c lower than 7% after 26 weeks was similar for insulin degludec and basal bolus. And complementary effects of basal insulin and GLP-1 receptor agonist therapy, efficacy probably more with on HbA1c and reduced gastrointestinal side effects. Fixed ratio combination of basal insulin and GLP-1 receptor agonist, we have two molecules. We have GLP-1 receptor agonist liraglutide with insulin degludec lira, and we have lexinatide with insulin glargine lexi. And the utility of fixed radio basal insulin GLP-1 receptor agonist combination in clinical practice give high percentage of the patient achieving HbA1c target with lower risk of hypoglycemia compared with the insulin alone, weight loss versus weight with gain with insulin, reduced frequency of gastrointestinal side effects due to slow titration with low initial dose of GLP-1 receptor agonist, and increased patient acceptability. Type 2 diabetes mellitus suitable for fixed basal insulin GLP-1 receptor agonist if HbA1c above 7% or even 8, advanced type 2 diabetes and some complication already, insulin therapy delayed for some time, at higher risk of hypoglycemia or with overweight. And the combination of basal insulin with GLP-1 receptor agonist has scientific basis, has complementary action and additive actions. And adding GLP-1 receptor agonist to basal insulin equally effective compared to add prandial insulin. And we have fewer injection, less glucose monitoring required, lower insulin dose, weight benefit, and less hypoglycemia, but more gastrointestinal effect and the cost and affordability. Rationale of co-formulation basal of insulin GLP-1 receptor agonist, the barrier to concomitant for use for individual products is more injection, lead to clinical inertia, and uncertainty of choosing starting dose, adding therapy, titration of each drug. That's why the combination is more important, is more efficient, effective. Rationale of co-formulation of basal insulin GLP-1 receptor agonists give benefits and provides pathophysiologic basal treatment, target both fasting and postprandial glucose, single injection, safe, effective initiation and titration algorithm, avoids uncertainty regarding titrating individual component, and minimize delays in achieving glycemic control. And when we see insulin degludec lira in comparing with insulin naive patients with type 2 diabetes not controlled on oral agents in study dual 1, we find that insulin degludec is more effective on HbA1c and on fasting the plasma glucose comparing to insulin degludec or to liraglutide. The same insulin degludec in insulin naive patients with type 2 diabetes not controlled on oral agents in study dual 1, the insulin degludec is more effective according to each percentage of each number of HbA1c and in the same of each independently of BMI. Insulin degludec in patients with type 2 with patient control not controlled on basal insulin, insulin degludec lira is more effective when we compare it to insulin degludec about HbA1c or changing in fasting plasma glucose. Insulin degludec lira in patients with type 2 diabetes not controlled on GLP-1 receptor agonist plus oral agent, insulin degludec lira is more effective on HbA1c. And it's the same when we use insulin degludec in study dual 7 and comparing with patient type 2 not controlled on insulin granulin plus oral agent, insulin degludec lira is more effective than on HbA1c, fasting plasma glucose, and plasma glucose during the day. What about now insulin-glargine lexi in insulin-naive patient with type 2? We find that insulin-glargine lexi is more better than versus patient on lexi or patient on glargine about the reduction and the control of HbA1c. The same insulin-glargine lexi in insulin-naive patient with type 2, Lixilan, the results are more interesting with insulin-glargine lexi on fasting plasma glucose, on the excursion, the reduction of the excursion of plasma glucose and the reduction of the weight change. The efficacy of insulin-glargine lexi in patients with type 2, not controlled on basal insulin, insulin-glargine lexi is better than glargine on the reduction of HbA1c. And at the summary, it's important to identify candidates for insulin therapy or GLP-1 receptor agonist, select appropriate insulin replacement, and challenges about concentrated insulin 500 regular insulin